The lighted stylet is an excellent airway intubation tool that is especially useful in patients with limited mouth opening, prominent upper teeth, or cap teeth. The minimum mouth opening required is the width of the tracheal tube. It is not suitable for patients with upper airway pathology, such as a tumor or abscess. It is an indirect intubation tool in which the glottic structures are not visualized. As such, neuromuscular relaxation is recommended to prevent glottic injury that might occur if the cords were not relaxed and abducted.
We will next demonstrate the endotracheal tube placement using a lighted stylet. As you can see here, the endotracheal tube is already loaded. However, the stylet should be lubed up and the battery checked to make sure that the light is working beforehand. The endotracheal tube is loaded on and secured onto the lighted stylet, and it should be bent where the stylet says bend here. That's an approximate hockey stick view of the bend. A number of people will also cut their endotracheal tube in order to reduce the length and reduce the play at the end of the stylet. For introduction of the lighted stylet into the mouth, this patient should first be paralyzed. This is to avoid any unseen trauma, as this is a blind technique. Typically, a tongue jaw lift is done with your left hand, and the jaw is advanced forward. The lighted stylet is then introduced without the light on in through the side of the mouth. The lighted stylet is introduced through the mouth and is then twisted until it is in a perpendicular position. Be sure not to advance it too far as to miss the glottis. The ambient light should be minimal, as this requires transillumination across the... Once in, you look for the transillumination on the midline skin that goes to the suprasternal notch. If the tip of the lighted stylet is not appropriately positioned, you may see light off to one side or the other. If it is in the esophagus, you will not see transillumination into the suprasternal notch. As you can see here, I have good transillumination across the neck skin. From here, I would advance it slightly forward. I would then pull out the stylet as I advance the tube inwards. I would then unsecure the tube from the stylet, pulling it out. I would blow up the cuff with air, secure the tube, and confirm with end-tidal CO2.
I get somebody to in a second. Yeah, it's there. Okay, and then lights out, please. Thank you. And lights back on, please. Thank you.
Oh, I'm sorry. Didn't realize you were filming.
Tracheal intubation is confirmed by capnography and end-tidal CO2 measurement, as well as bilateral auscultation of the lung fields.